Okay, all right. Well, welcome everyone. Thank you for joining. It's time for another edition of ACMT's National Journal Club. This is Steve Axe. I'll be your host. I just wanted to remind everyone of some ground rules here. If you are tweeting, please use the hashtag ACMTNJC. We would love to hear from you, so raise your hand if you would like to just jump in there with a comment. So that would be great. And particularly, we'll make some breaks between the articles covered. I would really like to thank our presenters today, the Rocky Mountain Fellowship Program, led by Dr. Chris Hoyt, and the fellows, John Ragu and Dr. Alexa Camarena-Michel. And we will have some special guests today, including the good Dr. Barry Rumack, and hopefully also to get some of other esteemed colleagues on the line. I believe I see Dr. Steve Curry and Dr. Michael Buehler should be available too. So really looking forward to that. So with that, let me turn it over to you, Chris and fellows.
Thanks, Steve. Appreciate the opportunity to present at the National Journal Club. And specifically this particular topic, which I feel like has gained a lot more attention recently. I know that there are people who have been doing some work in this area for a bit, but appears to be kind of something that people are talking about a little bit more. And so actually for John and Alexa, our two second-year fellows, had this idea to present this, which I think was great and timely. And I see that Dr. Curry is on the line, who's done some work in this area, as well as Dr. Rumack, who we're fortunate to have as our faculty discussant for this. So without further ado, I'll turn this over to Dr. Ragu to go ahead and start.
All right. Hi, everybody. Thank you for joining us today. My name is John Ragu, and I'm a second-year medical toxicology fellow. Today, we'll be discussing selected journal articles relevant to the topic of the potential role of fomepizole or methylpyrazole as an adjunct for high-risk acetaminophen toxicity. We will begin the discussion with a brief introduction to the topic, the relevant background pathophysiology of acetaminophen hepatotoxicity, followed by selected animal studies. We will then transition into a discussion of a case report and a human volunteer study. This case report by Zell Cantor and colleagues, published in 2013, reports a case of a massive acetaminophen overdose with a reported peak acetaminophen concentration of 1,193 micrograms per ml, and had a favorable outcome with treatment consisting of only IV NAC. The unique facet of this case report is the empiric administration of fomepizole for a possible toxic alcohol exposure prior to the diagnosis of acetaminophen overdose. Although the authors of this report published this case to highlight the fact the patient had a favorable outcome with only IV NAC despite the strikingly high acetaminophen concentration, the following letter to the editor, published in 2016, speculated the favorable outcome in the case may be related to the empiric administration of IV fomepizole. The authors of the letter suggested that perhaps the animal data from the mid-1990s and early 2000s for fomepizole in a rodent model of APAP hepatotoxicity, limited hepatonecrosis, and other studies demonstrating potent inhibition of CYP2E1 by 4MP may be clinically relevant in humans. Moving forward from 2016, a number of case reports and series have appeared in the literature commenting on this. Woolam and colleagues, Rampon and colleagues, and Shaw and colleagues. We are most familiar with the role of fomepizole in the treatment of ethylene glycol and methanol exposure via its inhibition of alcohol dehydrogenase. However, these cases in the literature and prior basic science findings raise the question of how might fomepizole provide benefit as an adjunct in selected cases of acetaminophen toxicity. And the publications we present today attempt to provide an answer to that question. To aid in the discussion of the following animal studies, we will briefly review the pathophysiology of acetaminophen toxicity. The illustration on this slide shows the traditionally taught textbook version of how toxicity arises from an acetaminophen overdose. However, much more occurs after the production of NAPQ. After the depletion of glutathione, high concentrations of NAPQ form APAP protein adducts, especially on mitochondrial proteins. Components of the electron transport chain are affected, which compromises respiratory chain function and results in the generation of free radicals like superoxide and the highly reactive peroxynitrite. Mitochondrial antioxidant defenses are overwhelmed, resulting in oxidant stress and oxidation of enzymes like thioredoxin. In the cytosol, thioredoxin results in the detachment from its binding partner, apoptosis signaling regulating kinase, and is activated. Activation of this enzyme, mixed lineage kinase 3, and MKK4 phosphorylation then activate cytosolic C-Jun-N terminal kinase, also known as JNK, via phosphorylation. And this enzyme will be highlighted in the upcoming animal studies. Phosphorylated JNK then translocates to the mitochondria, resulting in further inhibition of electron transport and amplification of mitochondrial stress. Inducers of apoptosis, like BAX, GS3-key beta, also translocate to the mitochondria. These events activate the mitochondrial permeability transition pore and release mitochondrial intramembrane proteins such as SMAC, endonuclease G, and apoptosis-inducing factor. Ultimately, DNA fragmentation occurs, followed by cellular necrosis. In the coming articles, we'll see how 4MP factors into this mechanism. So the first article that we're going to discuss is titled 4-methylpyrazole protects against acetaminophen hepatotoxicity in mice and primary human hepatocytes by Akapo and colleagues, published in Human and Experimental Toxicology in 2018. The objectives of this article were to assess the protective mechanisms of 4MP in a mouse model of acetaminophen toxicity and assess the protective effects of 4MP in primary human hepatocytes exposed to toxic concentrations of acetaminophen. In terms of the study design, mice were fasted for 15 hours and then were assigned to 3 groups: intraperitoneal injection of acetaminophen at a dose of 300 mg per kg, intraperitoneal injection of acetaminophen 300 mg per kg plus 4MP at 50 mg per kg, or an intraperitoneal injection of 10 milliliters per kilogram of normal saline. The mice were then euthanized at 30 minutes and 6 hours, and blood and liver tissues were collected at these time points. For the human hepatocyte portion of the study, the cells were isolated and plated and treated with either 10 millimoles of APAP, 2 millimoles of 4MP, or 10 millimoles of APAP plus 2 millimoles of 4MP for 24 hours. Results were expressed as standard error of the mean. Students' t-test was used to assess statistical significance between 2 groups, and then one-way ANOVA and student Newman-Pools test was used in comparing variance between multiple groups. A p-value less than 0.05 was considered significant for all tests. So this is figure 1, and it demonstrates the protective effect against acetaminophen in the mouse model. So co-treatment with acetaminophen plus 4MP almost completely eliminated acetaminophen toxicity at 6 hours, as indicated by the low plasma ALT concentrations, and then the absence of detectable centrolobular necrosis, and the absence of detectable nuclear DNA damage noted in panel C. This is figure 2, and it illustrates the Western blot findings of 4MP co-administration and JNK. In animals treated with acetaminophen alone, there was JNK activation and mitochondrial phosphorylated JNK translocation, whereas co-treatment with 4MP prevented JNK activation and translocation of phosphorylated JNK to the mitochondria. Figure 3 on the right is a bar graph showing cytosolic and mitochondrial BAX, SMAC, and AIF concentrations relative to the controls. Acetaminophen caused translocation of BAX to the mitochondria and induced the release of AIF and SMAC into the cytosol. In animals co-treated with 4MP, there was attenuation of AIF and SMAC release by 80% and 65% respectively, and then BAX translocation was only inhibited by 30%. In figure 4, the total glutathione in the 4MP group allowed only 33% depletion of glutathione compared to the control. In contrast, the acetaminophen alone arm depleted hepatic glutathione by greater than 90%. This is an additional image from figure 4. This shows 4MP treatment almost completely prevented the formation of protein adducts, whereas acetaminophen caused extensive protein adduct formation. And this is figure 5, and it shows the measurement of metabolites measured 30 minutes after administration in the two groups. Image A shows the concentration of unmetabolized acetaminophen and glucuronide were not affected by 4MP, and then acetaminophen sulfate and cysteine were significantly reduced by 4MP. In panel B, all metabolites associated with the detoxification of NAPQ by glutathione were reduced by 85 to 100% in the 4MP group, suggesting that 4MP effectively inhibited the formation of reactive metabolite of acetaminophen by P450 enzymes. Additionally, findings from liver homogenate from this publication also show that 4MP dose-dependently inhibited the P450 enzymes involved in acetaminophen metabolism. Figure 7 presents the findings of the human hepatocytes portion of the study. Panel A shows phase contrast images that reveal acetaminophen-exposed primary human hepatocytes resulted in cell death, whereas 4MP plus APAP mitigated these effects. Panel B is a bar graph of percent ALT in the media amongst the different groups. In the acetaminophen group, there's 40% of cellular ALT in the medium compared to less than 10% ALT in controls. In the presence of 4MP, there was similar ALT release when compared to the control in 4MP alone group, suggesting prevention of acetaminophen-induced cell death of the primary human hepatocytes. So the authors concluded the following. In the mouse model, co-treatment with 4MP almost completely eliminated extensive liver injury caused by acetaminophen, which is indicated by the absence of cellular necrosis, DNA fragmentation, ALT elevation, prevention of JAK activation and translocation, and attenuation of batch translocation. Additionally, 4MP inhibits cytochrome P450-dependent formation of the reactive metabolite and prevented acetaminophen adduct formation. And lastly, 4MP appeared to protect against acetaminophen toxicity in primary human hepatocytes as well. All right, any questions or comments about the first paper?
That was excellent, John. Yeah, and again, if anyone would like to chime in, please raise your hand. We'll be happy to acknowledge you, or if you'd rather put something in the chat, we can also bring up that up as well. You know, having read these papers carefully, I think what you guys have just introduced is a very complicated mechanism, and you know, I think the effect of the study was really it was really absolutely fascinating. Some of the methods I found very interesting, that this was an intraperitoneal injection of acetaminophen, you know, very different than humans, obviously. And then also, you know, I found it interesting the dosing of 4MP, like 50 milligrams per kilo. Just kind of wondered, you know, why. I mean, again, proof of concept, it makes sense. But, you know, I think that was just an interesting thing. Did you have any idea, like, how they came on that dose?
Yeah, I know, and maybe Barry might be able to add to this as well too, but I know the 50 mg per kg have been used in prior studies as well too, and that equivalent dose is 4 mg per kg in humans, so it's definitely an underestimation of what a human would be receiving. But I don't know if Barry had any other additional remarks on why those particular doses were chosen, or the concentrations that were chosen for the hepatocytes as well too.
Great. And Dr. Rumack, I've got you unmuted if you wanted to say anything.
No, it was to try to replicate what was thought to be the concentration in the hepatocyte, the standard dose of hepatocyte.
Got it. There's a question, how do they choose concentration for hepatocytes? I'm not sure.
Yeah, that's how it was calculated.
Got it. And there's a question, how soon after APAP exposure that the 4MP still shows benefit?
I think that'll be covered in the next paper.
The next paper, right, exactly. Okay, great.
Yeah, that's the one, obviously, limitation of this. This is like not replicating, you know, an overdose situation where you're co-administering the antidote at the time of overdose, but the following paper will address the delay in acetaminophen and then the timing of the administration of 4MP.
Great. Well, with that, why don't we move on to the next one?
Perfect. All right. The next journal article is titled Delay Treatment with 4-Methylpyrazole Protects Against Acetaminophen Hepatotoxicity in Mice by Inhibition of C-Jun-N Terminal Kinase by Akapo and colleagues. And this was published in Toxicologic Sciences in 2019. The aim of this study is to answer if delayed treatment, that is after the metabolism of acetaminophen is complete, with 4MP will still have a protective effect in the mouse model. The authors also aim to study the potential mechanism of the protective effect of delayed 4MP treatment. In the interest of time, we will only be able to highlight the key results and not really dive into the findings of the 4MP docking in JNK1, JNK2, and then junk kinase activity in the presence of 4MP. So in terms of the methods, it's similar to the prior study with some mild modifications. So this study primarily focuses on the intraperitoneal injection of acetaminophen, 300 mg per kg with or without 4MP at 50 mg per kg at 90 minutes, and then uses the additional 4 groups to investigate the effects of higher acetaminophen dose, higher 4MP dose, and the administration of NAC. The administration time is 90 minutes. Since in the mouse model of acetaminophen toxicity, this is a time point in which acetaminophen has been completely metabolized for a dose of 300 mg per kg. Additionally, the mice were euthanized at 3 hours, 6 hours, and 24 hours post-acetaminophen administration. The control not included in this image is intraperitoneal injection of 10 mils per kilogram of normal saline. So this is figure 1 from the paper, and we see the difference between acetaminophen-induced liver injury with and without delayed 4MP treatments. Panel A shows plasma ALT concentrations for each group at 3 and 6 hours. The APAP group showed a time-dependent increase in plasma ALT concentrations, and the 4MP treatment group demonstrated no elevation of plasma ALT concentration over time. Panels B through G show that 4MP effectively reduced other parameters of cell injury, like central lobular necrosis and DNA damage. It is important to note that in the supplementary material, this protection was not appreciated when the treatment was delayed to 3 hours. Figure 2 is a Western blot that shows 4MP treatment at 1.5 hours after acetaminophen had no effect on cytosolic junk activation at 3 hours, but eliminated mitochondrial translocation. At 6 hours, 4MP prevented both cytosolic junk activation and mitochondrial phosphorylated junk. This is figure 3, and it's looking at protein adducts measured at 3 and 6 hours after acetaminophen. There was no significant difference of APAP protein adducts between groups at 3 hours. There was a decline of adducts at 6 hours in the 4MP-treated mice. This is also from figure 3. This is a Western blot that shows no AIF, apoptosis-inducing factor, is present in the cytosol of untreated mice. AIF release was observed at 6 hours after acetaminophen overdose, and 4MP treatment almost completely prevented AIF release, which suggests that 4MP may have prevented mitochondrial dysfunction. Again, this is from figure 3. Panel C shows that 4MP-treated animals had higher hepatic glutathione concentrations compared to acetaminophen alone at 6 hours. Panel D includes the glutathione bisulfide to glutathione ratio, which is an indicator of mitochondrial oxidant stress. The 4MP-treated animals had a ratio of less than 1%, which is close to the values noted in the control group. And then finally, in figure 6, we look at the introduction of NAC and increased doses of acetaminophen and 4MP. In panel A, animals were treated with either 50 milligrams per kilogram of 4MP, 500 milligrams per kilogram NAC, or both at 90 minutes after acetaminophen with plasma ALT measurements at 6 and 24 hours. There was a trend of slightly higher injury after 4MP treatment compared to NAC and NAC plus 4MP at 24 hours. The higher dose of 4MP, 200 mg per kg, did not affect the results. In panel B, the intraperitoneal acetaminophen dose increased to 600 milligrams per kilogram, and both NAC and 4MP reduced plasma ALT concentrations by 90%, with 4MP slightly more effective than NAC at this increased acetaminophen dose. The authors made the following conclusions about this mouse model. Delayed treatment with 4MP was still effective in protecting against acetaminophen hepatotoxicity at 6 and 24 hours, suggesting another mechanism other than inhibition of CYP2E1, such as possible JNK inhibition. 4MP acts as a JNK inhibitor based on molecular docking and JNK kinase activity, which was not discussed due to time constraints. Other conclusions include 4MP may accelerate the clearance of acetaminophen protein adducts. Delayed NAC is slightly more protective than delayed 4MP when the acetaminophen dose is 300 mg per kg. And delayed 4MP was more effective than delayed NAC in the acetaminophen dose was increased to 600 mg per kg. All right, any questions or comments regarding this article?
Again, fascinating paper, great extension of work from the first paper. And again, please raise hands or pop a question into the chat function. I found it interesting the mixed results with combined NAC and 4MP. Obviously, we can't extrapolate anything to humans, but I think those effects were quite interesting.
Yeah, and I think you're probably getting some effect of the 4MP at the higher dose of acetaminophen because you're still having NAPT production by CYP2E1 because you're still at the 90 minutes is just for the 300 mg per kg, and so that time is going to be extended for 600 mg per kg. So there's probably, you're getting some dual benefit of the CYP2E1 inhibition at that time point with the higher dose.
Right. Okay, I'm not seeing much chatter in the chat room. Did you guys have any other comments at this point, or you want to move on?
We can go ahead and move on.
Okay.
I'll hand it over to my co-fellow, Alexa Camarena-Michel.
Hello, everyone. I'm Alexa Camarena-Michel. I am a second-year toxicology fellow at RMPDS. And as John mentioned, there have been many case reports and case series that have described the effectiveness on 4MP and acetaminophen toxicity. Shaw's case report is one of them that we would like to highlight. So this case report describes a 33-year-old male with a history of ethanol abuse who presented to the emergency department for abdominal pain after taking 50 tabs of 500 milligram acetaminophen over the previous 2 days. He was otherwise taking gabapentin and quetiapine. The patient presented mildly tachycardic to 102, mildly tachypnic to 26. He was normotensive and was saturating well on room air. His initial labs were notable for an acetaminophen concentration of 337 milligrams per liter, an AST of 137 international units per liter, and an ALT of 194 international units per liter. An ABG revealed a pH of 7.24 with a PCO2 of 23 and a bicarb of 10. 4 hours after presentation, the patient was found to have a lactate of 4.1 millimoles per liter and an INR of 2.2. This figure demonstrates the patient's clinical course. 9 hours after arrival, the patient was started on IV N-acetylcysteine, a 3-bag protocol. After 9 hours at a rate of 6.25 mg per kg per hour, the NAC was increased to 15 mg per kg per hour at 23 hours. Additionally, a 15 mg per kg dose of 4MP was given 11 hours after presentation because of concern for severe acetaminophen toxicity. The patient's acetaminophen concentration slowly downtrended from 337 milligrams per liter at presentation to 134 at 19 hours and 20 at 42 hours after arrival. Peak transaminases occurred 2 days after admission with an AST of 198 and an ALT of 301. INR peaked at 3.1 24 hours after arrival. The patient received NAC for 3 days and was ultimately medically cleared. The case report mentions that this patient had multiple markers for a poor clinical outcome. For instance, the patient's cross product, the multiplication of his higher transaminase and acetaminophen concentration, was well over 10,000 milligrams per liter times international units per liter, corresponding to a high likelihood ratio of 250 for hepatotoxicity, with hepatotoxicity being defined as a peak transaminase of greater than 1,000. In this case, the patient's cross product was 65,378. Additionally, the patient had a history of ethanol abuse and presented with a negative ethanol concentration, so he may have had a higher risk of hepatotoxicity secondary to CYP2E1 upregulation. NAC administration was delayed over 8 hours, which also increases his risk for hepatotoxicity. Additionally, his serum acetaminophen half-life was 10.2 hours, which is well above 4 hours and also increases the risk for hepatotoxicity. Lastly, his pH was less than 7.3 several hours after arrival, and his lactate was greater than 3.5. This paper suggests that there was a possible adjunctive role of fomepizole in the treatment of acetaminophen-induced hepatotoxicity. Some limitations and confounders that were mentioned in this case report were that other causes of liver injury were not tested for. Additionally, the patient did have a higher dose of NAC 23 hours after arrival. So with that, we can take comments and questions.
I see Dr. Bueller is on the call, and I saw that Dr. Shaw was on the call. Do you guys have anything you want to add to the case report?
Michael, I've unmuted you.
Yeah, I was trying to figure that out. Yeah, thanks for presenting. You did a very nice job kind of pulling that all together. You know, the man wasn't really forthcoming initially, which is why there was that initial delay in making the diagnosis and then finding that really elevated acetaminophen level. And then a little bit of the delay in getting the fomepizole into the patient had to do with some institutional, you know, sort of allowing the release of the use of fomepizole in this patient required a few hoops to jump through and convincing of individuals. I just figured I would flesh out those numbers as to why those delays were there.
Hey, so Michael, this is Chris Hoyt. Really quick question. When did you decide? Did you decide in the door that this person was at risk, given the delay, and that you might use fomepizole in this person?
So we have the case initially was a poison center case, and then obviously once things were going, we were speaking physician to physician. But basically, we have a sort of a tripwire that anybody who has a cross product over 10,000, we're getting on the phone, and the first person on the phone was Dr. Shaw, who took one look and said, I think we should use fomepizole in this case. And so we pretty much, with this type of story, right out of the gates, as soon as we realized what was going on, we started down that pathway in addition to making sure that we were going to try to jack the NAC dose up to what we usually recommend.
Very nice, thanks.
Okay. And also, Dr. Shaw, I've also unmuted you if you had anything to add.
Thank you. Yeah, exactly as Dr. Bueller was saying, I got the initial call, and the initial impression from the primary team was that this was actually a salicylate based on the initial tachycardia and tachypnea, and that was part of the delay in treatment as well, and then the acetaminophen level took a while to come back, and this seemed like a good case to try it on because there was not much human data at the point where this case occurred, which was over 12 months ago, almost 18 months ago. And so I felt that if we were going to do it, we needed a lot of risk factors to show that, you know, there's lots of good animal data, but this would be a case where the benefits would greatly outweigh the risk of a drug that doesn't have, again, that same human data literature so far.
I see there's a question about why do we increase the NAC dosing. That is because of standard practice, both at our host institution system as well as the state poison center, is that we go with the same bolus, but then we go with 15 milligrams per kilogram per hour until either improvement or death. And RUMAC has commented on this before, and there's questions about is the the 6.25 per hour terminal amount sufficient in patients that are well outside of the norm as were studied with the 300 milligrams per kilogram per day that you get with the acetadote. And so we did this because this is what we do for sick patients, and we sort of pushed for it. It really was sort of independent whether the 4MP was used or not. That's just what we do.
Yeah, since we do have Dr. Rumack on the line, did you want to, weigh in your thoughts on that about increasing dose versus not?
It seems to me that this is a totally appropriate use of calculating the amount of acetaminophen in the patient and the delays together, and that they decided they needed to have more on to keep the stoichiometry appropriate. So I thought this was a great case report for a number of different reasons. So just to comment on that, I think that's correct. I think that the 4MP use in this case was very interesting because of the possibility of this patient getting worse, whereas the 4MP given, as we know, even in animals late, is probably helpful. So this case kind of helps buttress that information.
Great, thank you. There's a question from folks at WashU. Yeah, I have a similar question. Is how do we explain the increased INR with a very low AST ALTP? Do we think that's related to the chronic alcoholism? I'll throw that over to Michael and Kartik.
I believe there's also an effect of elevated acetaminophen levels that are really elevated like this if you have it up for long enough, that I thought the PT went up from without hepatic injury. So there's multiple factors. There's the alcoholism, there's the effect of the acetaminophen on the PT, and then there's the potential for a small injury that seems a little out of sync, though I will grant you that, with the LFTs.
Right. Okay, there's one final question about, was there anything that suggests changes in half-life before and after 4MP in this patient?
I have to rerun the numbers, but I have a feeling that we have 3 points, and I think that the variance of that, I'm not certain that we would be able to conclude. I can take a look and see, but I'm concerned about trying to draw a strong conclusion based on just 3. 2 points always make a straight line, so that's all.
Yeah, not enough data points probably. All right, great. Really fascinating case report. All right, should we press on to the last paper?
Yeah, sounds good. So the fourth article that we would like to talk about is the effect of 4-methylpyrazole on oxidative metabolism of acetaminophen in human volunteers, written by King et al. The objective of this study was to assess the effect of 4MP on acetaminophen metabolism in humans. Specifically, it sought to answer the question, to what degree does omeprazole prevent NAPG formation in humans who have ingested acetaminophen? The primary outcome in this paper was the measured fraction of ingested acetaminophen excreted as total oxidative acetaminophen metabolites in urine over 24 hours after acetaminophen dosing. The oxidative acetaminophen metabolites excreted in the urine are a reflection of the fraction of ingested acetaminophen that was ultimately metabolized by CYP2E1. The methods of this study included recruiting 6 healthy volunteers who were randomized to a blind draw from an envelope to start with one of 2 treatments, either treatment A, which included just APAP, or treatment P, which included APAP plus 4MP. They were all asked to abstain from acetaminophen use for 2 weeks prior and during the study period, as well as to refrain from ingestion of ethanol the 5 days preceding each treatment. Patients performed a 2-hour fast prior to treatment, and subjects emptied their bladders. They were given an 80 milligram kilogram dose of acetaminophen by mouth, which was considered time 0. During treatment B, acetaminophen was administered immediately, which was considered time zero. During treatment B, acetaminophen was administered immediately upon completion of the first 30-minute 4-MP infusion. Dosing for 4-MP was 15 mg per kg, followed by a 10 mg per kg dose 12 hours later. Urine was collected for 24 hours, and blood was collected at various time intervals throughout 24 hours. This was a crossover trial, so each patient served as his or her own control. Paired t-test with an alpha of 0.05 was used for statistical analysis. Table 1 demonstrates the characteristics of the study participants. Notably, 6 patients completed both treatments of the study, but only 1 subject was excluded because of an extra dose of acetaminophen taken at home during the study. Figure 1 demonstrates the percentage of acetaminophen recovered as oxidative metabolites in the urine. In panel A and B, we see that the percentage of oxidative acetaminophen metabolites APAP-NAC and APAP-CIS decreased in the APAP plus 4-MP condition. In panel C, the percentage of total oxidative metabolites recovered in 24-hour urine decreased from 4.48 to 0.51% when comparing acetaminophen to acetaminophen plus 4-MP. Notably, no acetaminophen glutathione was detected in any urine sample. Figure 2 shows 24-hour urinary excretions of unchanged acetaminophen, as well as non-oxidative metabolites, APAP-GLUP and APAP-SULF. The dotted lines connect individual subjects and demonstrate that there was no consistent changes observed for individual subjects between the 2 treatments. In figure 3, we see the plasma 8-hour area under the curve values that were obtained for oxidative metabolites for treatments A and B. Here, the mean for treatment A was higher than the mean for treatment B. This was demonstrated in both APAP-CIS and APAP-NAC. As in urine, no acetaminophen glutathione was detected in any plasma sample. No protein adducts were detected in any plasma sample from any subject. Figure 4 shows 8-hour area under the curve values that were obtained for acetaminophen and non-oxidative metabolites such as acetaminophen, APAP-GLUP, and APAP-SULF. Here, peak acetaminophen concentrations and time to peak were similar in both treatments, with only minimal concentrations still detectable at 24 hours. By inspection, peak plasma concentrations of non-oxidative metabolites appeared greater and more sustained in the APAP plus 4-MP condition. This paper concluded that there was a decrease in the percentage of oxidative acetaminophen metabolites in both the urine and in the plasma in human volunteers after receiving fomepizole. The authors in this paper attribute this effect to inhibition of CYP2E1 by fomepizole. Limitations mentioned by the authors include a small sample size as well as an unknown applicability to human overdoses. Are there any questions or comments about the crossover trial?
Hi, this is Chris Hoyt also. I see Steve, Michelle, Phoenix Group is on the call. As a result of this work, are you guys using fomepizole in your group? And if you are, what kind of criteria do you use to determine who's going to get fomepizole?
Yeah, this is Steve. We're here in Phoenix on various different offices, so I just want to make sure I am the one who got unmuted here.
Yeah, you're unmuted. We can hear you.
Okay, thanks. Yes, we do use fomepizole, but it's not through any standard protocol. It's on an individual physician basis. And the main time we use it, I would say in general, are late presenters who still have elevated blood acetaminophen concentrations, or late presenters who come in whose transaminases are beginning to rise. The latter indication is mainly based on the data on inhibiting C-junk in the rodent model, while the former reason would be for both inhibiting C-junk, but of course mainly by inhibiting P450.
Got it. Excellent. Another comment, Steve. What I think is wonderful about this particular paper is the collaboration between yourself, the folks in Colorado, and the group that did the basic science work at Kansas. I guess one question, since we do have you, is this is very sophisticated testing, and I think many programs would love to do this sort of thing. how do you go about getting these tests done? Is this something you've developed in-house, or how does it happen?
Well, just briefly, we've been doing acetaminophen toxicity research with our colleagues with Hart Majeski at KU, or the University of Kansas in Kansas City, for way over a decade, and also have worked with the Center for Human Toxicology, the Center for Human Toxicology at the University of Utah. And at the University of Utah, we can get all these acetaminophen metabolites as well as adduct levels, and we can get the same also out of the University of Kansas. So when these are not clinically available tests that we order, but are research tests that these centers run in conjunction with us.
Great, thanks. Yeah, so those relationships are really critical to do any kind of meaningful work like this. Yeah, that's great. Did anyone else at Phoenix have any comments? Unmuted you folks as well.
So we wanted to just one last thing before we wrapped up. So the group in St. Louis has been actually doing some work in this particular area. I think that they're presenting this at this year's NACCT, looking at a small series of patients that they used fomepizole as an adjunctive therapy in some of their patients that are poisoned by acetaminophen. And so they did some work here, and so they have a poster that's coming up that they're going to present, but they also have recently published the article. I think the case series is 6 patients rather than 7 in Toxicology Communications. So the group in St. Louis has actually been doing this work for a couple of years. I believe 2016, the group from St. Louis can correct me on that if I'm wrong. But we're just going to show a little bit of work that the St. Louis group has done, trying to round this out, because I think we'd be remiss by not at least mentioning this, and also calling attention to the work that they published.
Yeah, thank you, Dr. Hoyt. So as Dr. Hoyt mentioned, this is a case series of 7 patients with acetaminophen overdose who were treated with standard NAC therapy as well as 4-MP. In this case series, no patients developed significant liver injury despite having persistently elevated acetaminophen concentrations. So this graph shows that the half-life of acetaminophen in all 7 cases was greater than 4 hours, but despite this, there was no significant hepatic injury that was seen. The max ALT across all 7 cases was 79, and the max AST was 69.
Is anybody from the St. Louis group on the call?
I believe that they are. Let me see. Actually, Wash U, I am unmuting you if you can hear us.
This is Chris. Hi, Steve. Hi, Chris. Wash U group to touch on some of the work that they've done in this area also.
Hi, are you guys there?
Yeah, we're here. Can you hear us?
Yep.
Hey, a good topic, and looking forward to Jeff's presentation at the ACMT pre-symposium later this week as well. But yeah, so I wasn't involved in this case series other than as an editor, but I'm sure Tony Scalzo, if he's on the call, will provide more details about it. But and then I'd offer to highlight, I put it in a tweet already, the systematic review on this topic that just got published in ClinTox Online about 4 weeks ago. So, but we do this occasionally. Again, as with Steve Curry's shop, it's on a kind of case-by-case basis and attending preference. I think we've done it at least 2 times, I think, that I can think of in the past several months or so. Like Steve's group.
Yeah, Tony, I've got you unmuted now.
Can you hear me?
Yeah.
Thank you. Yes, I really enjoyed this. I had some technical difficulties. I'm in a brand new hospital with above state-of-the-art technology, but they couldn't connect a laptop to 65-inch TV. I could watch football on it, but I can't get to you guys. So I'm up off of my iPhone 11 Pro Max. So a little bit of real estate. Appreciate the graph at the end. And yeah, we're actually now up to 10 cases, but when we submitted our case series to NAC, of course, we were at 7. And we have, this is not a randomized controlled trial. This is not a prospective trial, but it is being used prospectively if patients show exceptionally high acetaminophen levels that are not decaying at the proper rate. And if I had a nickel for every time that a resident said to me, but we're using NAC, isn't that dropping the level of acetaminophen? I'm like, you're killing me. But okay. So all of our cases had exceptionally, or at least close to exceptionally high levels. Several had very high levels. 791 was one of our latest cases. And the confounder is that a couple of cases we did do CRRT on. But one of them was because there was also concomitant salicylate poisoning, and that complicated a lot of things, obviously. But I think it's just been remarkable, and I welcome the invitation by Barry to be part of any clinical trial because this is only a beginning. And I think our study probably just really speaks to safety. I would like to say it speaks to efficacy, but it's difficult to say with other things going on at the same time. And, not the whole country. I mean, credit to Mike Mullins. I teach in the fellowship program with Mike and Evan for the last 5 years. But Mike and the group there at WashU started the one bag method, which I tried to get adapted in our institution for a number of years, and finally we do. So not everybody uses the 12.5 mg per kilo per hour. Some people use 15, and some people are back at 6.25. So it's hard to know, but we have historical controls that I could pull up that show that patients with these kind of levels and these kind of decay kinetics are actually not doing well with just NAC, even at 12.5, because I've been doing the fomepizole since late 2016, 2017, and we've been doing the higher dose NAC for quite some time now. So I think that's the challenge, is trying to separate. I don't think we're anywhere near yet saying just use 4MP alone, but I'm impressed with the effects is what I can say.
Tony, there's a question in the chat. Are you redosing the 4MP or just a single dose?
Sometimes. One of the cases we did dose it twice after the loading dose, and that was in part more to the reason for its removal by CRRT than it was for my conclusion. Because, I mean, if you're obviously, some of these papers discuss this, the 50 per kilo murine dose, probably equivalent to 4 per kilo human dose, and we're already giving 15 per kilo, almost 4 times that amount. And I think the KI, I'm not sure what the KI is, but I think we're inhibiting not only CYP2E1, but also interfering with J&K junk. And I think it's an impressive, we've even had some remarkable recoveries in patients who presented so late. We have one of the cases we have recently that I haven't included in the series, because I'm not sure she would meet criteria by our standards, but she came in with a level of 10.8, but it was only discovered like 17 hours after presentation because they thought she was septic for some other reason. She came in, transferred to Western Community Hospital, and liver failure. Transaminases were in the thousands. And we, of course, started IV NAC, even if we weren't sure it was due to the acetaminophen, but I'm pretty sure it was. When we got a history, it was pretty clear that she was taking excessive doses of NAC, but not that much. She was taking a gram every 4 hours, but around the clock, so 6 grams a day for 2 to 3 days. And I mean, we can't find any other cause for it. And her transaminases started to come down in a pattern that I would not just explain by normal recovery or benefit from NAC. So I'm thinking it's going to be a useful drug in the future. We just have to study it more.
Yeah. One more question in the chat. I assume we're talking about giving the 4MP with NAC.
Yes.
Yeah.
I don't think we're anywhere near that point yet. Barry and I have had some communication about that, conversations. I think that in an animal model or human hepatocyte model, sure, it's an interesting concept, and maybe with a super therapeutic dose with volunteers, we can see what it does is 4MP alone compared to to NAC, but we're using it as an adjunct. We have only used it as an adjunct.
Right. We definitely don't want to get ahead of ourselves. There's
Exactly. I agree.
Yeah. Excellent. Thank you.
You're welcome.
Okay. Chris and gang, any further wrap-up comments?
No, it's good to do this and hear everybody's perspective. And we have in Denver, we've been discussing doing this, trying to decide whether we're going to do this kind of as a standard thing across our shops or not. And so we're currently debating this using this evidence that we've talked about today. So it's been great to dive into this and really kind of try to make a quick decision what we're going to do clinically based on the evidence. So.
Great. Well, yeah, I'm not seeing further questions. Thank you so much, Chris, John, Alexa. That was really well done, very well presented. Thanks to all the guests that made it on the line and added to the conversation. The next National Journal Club will be November 10th, and it will be presented by the UT Southwestern Group. So we'll be looking forward to that, and you'll get announcements out soon. Thanks, everyone. See you next time.